the staphylococcus epidemics that were occurring in the 1950s, there was a development of infection control committees. They didn't have a whole lot of authority. They just simply reported the data to the infection control committee made up of physicians and microbiologists and other people who had a little bit more power, I guess, to make things happen. Early on, it was pretty lonely. You were out there fighting your battles alone, it seemed.
When I first started, I think we were seen more as a necessary evil because the hospital had to check off a box to gain their accreditation. So at the time, infections were seen as inevitable or acceptable as long as you were at national benchmark or lower. So we've gone from infection control nurse to infection preventionists. That means we're called early, we're called first when there's a new program or a new service, so that we're not being called after the fact when there's a problem or an outbreak that we have to fix retrospectively.
A lot of that change was made possible by advocacy from APIC.
Before the pandemic, IPC programs were underfunded, understaffed. The pandemic exacerbated weaknesses in patient safety programs such as IPC. This essentially left healthcare facilities with insufficient capacity to prevent common and often deadly healthcare-associated infections.
Establishing an infection prevention staffing ratio for infection prevention and control is a critical piece that APIC needs to define. What is the right number of infection preventionists for a facility to have is an unknown that we intend to clarify. This is a very high priority for APIC.
One positive thing from the pandemic is that it brought more visibility to the field. People outside of healthcare actually know what we do, and they're excited that we are a member of their healthcare team.
And a greater willingness to collaborate with us, to not see us as police in the hospital, but to see us as collaborators.
The RIPs are incredibly well trained. And I think, I would love to see us really work on trying to drive more of our IPs into the senior executive suites of our organizations to ultimately elevate us.
APIC's going to be influencing the policy and regulatory environment to advance investment into building a national infection prevention workforce so that we can continue to strengthen infection prevention and control capacity throughout healthcare. Nowhere is that more crucial than in nursing homes and in long-term care facilities. APIC is pushing to mandate trained infection preventionists in long-term care facilities.
So all of those things combined ultimately creates kind of an ecosystem of trust, knowledge, and expertise that we really want to try to drive home to bear to better support our IPs back in working institutions.
These are things that have slowly evolved from the very beginnings to now where the infection control practitioner now can do so much more. Thank God for APIC.